Parkinson's disease is a progressive neurodegenerative movement disorder. While the exact cause of the pathophysiology is unknown, Parkinson's disease arises from progressive degenerations of the dopaminergic neurons of the substantia nigra. The chances of developing this condition increase with age. 1 to 2% of individuals over the age of 60 have this condition, reaching 3 to 4% of individuals over 80 years old. The most common symptoms of this condition include resting tremor, rigidity, bradykinesia, and postural instability. There is currently a lot of research showing the importance of exercise to manage and treat Parkinson's disease. Studies on animal models and human participants with Parkinson's disease have shown that exercise increases neuroplasticity in the brain. This theory is well supported and accepted through research, as it has also been found that self-produced activity can reshape the Parkinson's disease brain, and furthermore, the animal models studied suggest that neuroplasticity can contribute to behavioral recovery in Parkinson's disease. This neuroplasticity specifically drives motor and cognitive behavioral improvement, which are areas drastically affected in patients with Parkinson's disease. Other benefits of exercise have also been reported in Parkinson's disease populations, including brain health, improved immunity, increased blood flow, and neuroprotective properties. The current research available all suggests that exercise is extremely important as treatment in patients with Parkinson's disease. Resistance training, cardiorespiratory training, functional training, and group fitness, including dancing, have all been shown to improve Parkinson's disease measures on their own, however, have not been probably compared against different modes of exercise. Exercise in general has been shown to improve specifically and health-related quality of life, balance, and strength. Currently, more research is needed in this area to develop the best exercise treatment plan for those with Parkinson's disease. This study aims to organize and compare all available research to determine the most effective mode of exercise intervention to improve the lives and functionings of individuals with Parkinson's disease. This review aims to address the research question: in Parkinson's disease patients, what is the most effective mode of exercise intervention to improve Parkinson's disease measures, including quality of life and functional ability? Databases searched included PubMed and Google Scholar. Search terms included Parkinson's disease and exercise, Parkinson's disease and exercise intervention, Parkinson's disease and cardiorespiratory exercise, Parkinson's disease and resistance training, Parkinson's disease and group fitness, and Parkinson's disease and dance. Eligible studies included those that use participants with current Parkinson's disease undertaking a specific exercise intervention to measure Parkinson's disease outcomes against another form of exercise intervention, a control group, or both. Inclusion criteria was peer-reviewed articles in the English language. Articles more than 15 years old were excluded. The studies had to present quantitative data and not qualitative. 15 studies were originally located. 5 of these were excluded. 2 were excluded due to the age of the article, and 3 were excluded because they were case studies which only used one form of intervention and no control group. The relevant outcome measures were abstracted from the relevant articles. 10 eligible articles were included in this systematic review. Each study included at least one form of exercise intervention and a comparison that was either another form of exercise intervention, a control group, or both. Out of the 10 studies included, 3 studies used dance as exercise interventions. The 2009 study by Hackney and Earhart compared tango dancing, ballroom dancing, and a control group. This study found that both dance styles significantly improved Borg balance scale scores and meters walked in the 6-minute walk test. No significant improvements were found in the control group. The 2007 study by Hackney and colleagues compared a Tango intervention group with a strength and flexibility group. The study found a significant improvement in the Unified Parkinson's Disease Rating Score in both exercise intervention groups. However, improvements in the Borg Balance Scale were only seen in the Tango group. The final study by Duncan and Earhart compared a community-based dance class with a control group. The study found significant improvements in the balance and distance walked in the 6-minute walk test in the dance group, but no significant improvements in the control group. Two studies used cardiorespiratory training as the form of exercise for the intervention. The study by Fisher and colleagues used bodyweight supported treadmill training as a high intensity form of exercise. They compared this to a low intensity exercise group and a control group which only received education on exercise. The study found that the high intensity bodyweight supported treadmill training group significantly improved gait speed and weight distribution during sit to stand, which were not present in the low intensity or control group. A study by Canning and colleagues used home based treadmill walking as an intervention and compared it with a control group. The study found that there were no significant differences between the improvement in walking capacity between the treadmill group and the control group. However, the treadmill group significantly improved their quality of life when assessed at 6 weeks. Two studies included in this review compared resistance training with controls or other modes of exercise. A study by Hirsch and colleagues compared a combined resistance training and balance group with the balance only group. The study reported that the combined group improved balance scores significantly more than the balance group alone. A study by Kokos compared resistance training with a mixed stretch, balance, and strength and exercise program. This study reported the mean off medication unified Parkinson's disease rating score decreased more with resistance training than with mixed. Two studies included in this review compared combined mixed forms of exercise interventions. A study by Allen and colleagues compared a mixed exercise intervention consisting of resistance training and balance with a control group. The study found there was a significant improvement in the frequency of gait questionnaire and sit to stand times in the mixed exercise group that was not present in the control group. The study, however, did not find a significant difference in the risk of falls between groups. A study by Frazetta and colleagues compared an intensive rehabilitation treatment group with a control group. The intervention consisted of combined cardio, stretching, balance, gait, and functional training. The study reported better Unified Parkinson's disease rating scores in the intervention group compared with the control group. The last study by Lee and colleagues used 3 intervention groups: Tai Chi, resistance training, and stretching. The study reported that Tai Chi and resistance training lowered the incidence of falls, but not the stretching group. All of the included studies found some significant improvement in at least one intervention in relation to Parkinson's disease quality of life and functional ability. Allen and colleagues did not find a significant improvement in the risk of falls in the participants of the resistance training group when using the risk of falls algorithm. However, Lee and colleagues reported an improvement of incidence in falls in the resistance training group. These two studies were of approximately the same time frame, 6 months compared with 24 weeks respectively. So the varied results in relation to fall incident and risk with a resistance training intervention may be due to the algorithm to predict risk of falls not being accurate or the varied training methods between the studies. Allen's study used a predominantly home-based exercise intervention, whereas Lee's study was supervised, which may be the cause of the discrepancies between this research. The two treadmill intervention studies, Fisher and colleagues' bodyweight supported treadmill training and Canning and colleagues' home-based treadmill intervention, both found significant improvements in the outcome measures studied. However, the findings between these studies were different. The bodyweight supported treadmill training found functional improvements in gait speed and weight distribution during sit to stand. However, the home-based treadmill program did not find gait-related improvements other than improved fatigue. However, this study reported improved quality of life. The improved functional measures in this bodyweight supported treadmill training may be due to the intervention being supervised and workload was measured to stay at a level greater than 3 METs. Although treadmill walking is an exercise modality that patients can perform conveniently at home or in a gym setting, as Parkinson's disease patients are at a greater risk for falls, this modality may not be safe without supervision or safety precautions. A pilot study on the safety and feasibility of treadmill exercise in Parkinson's disease patients reported that out of 136 sessions, there were 11 falls or near falls and 9 episodes of systolic blood pressure drops of more than 20 milligrams of mercury. The study also reported that when harnesses were used, they were successful in preventing falls. Combined forms of exercise have had different results reported in the literature. Frazetta and colleagues reported improved unified Parkinson's disease rating scores in a combined exercise group of cardiorespiratory training, stretching, balance, gait, and functional training compared with a control group. However, Corcos and colleagues found the resistance training only group significantly improved on the unified Parkinson's disease rating score more than combined exercise group, including stretching, balance, and strengthening. This difference in the results of studies may be due to Frazetta's study being more intense and frequent than Coco's study. All three studies using dance interventions reported significant improvements in outcome measures, suggesting that dance could help improve functional status and quality of life in patients. All three studies showed an improvement in balance, and 2 out of 3 studies also reported an increased distance walked in the 6-minute walk test. As the dance exercise interventions have consistently reported improved outcome measures in Parkinson's disease, other forms of group training may also elicit this effect. Boxing training is another form of training which might improve functioning and quality of life in patients with Parkinson's disease. However, there were no eligible studies available, so this form of intervention could not be included in this review. The current research available suggests that boxing training improves balance, gait, and activities of daily living. However, this evidence is based off of 6 participant case series. Further research should include boxing training as an intervention in patients with Parkinson's disease in a randomized controlled trial. In conclusion, group exercise interventions such as dance is repeatedly shown in the research to improve Parkinson's measures and functional ability in Parkinson's disease populations. Other benefits has also been reported from cardiorespiratory training, including improved gait and quality of life. Resistance training has also been consistently reported in the literature to improve Parkinson's disease measures. These findings suggest that exercise in Parkinson's disease is extremely beneficial to Parkinson's disease measures, including quality of life and functional ability, as dance is shown to improve balance and functional ability repeatedly in the literature, and dance also has a cardiorespiratory aspect. Increased benefit may arise from a combined dance and resistance training intervention. Bodyweight supported treadmill training may also be beneficial in improving gait in the individual, especially if they have limited ambulating ability and are at greater risk of falls. Accredited exercise physiologists can translate this research into practice by suggesting group fitness ideas, including dance, to Parkinson's disease patients and combining this with resistance training. Accredited exercise physiologists should routinely measure balance, functional ability, and the Unified Parkinson's Disease Rating scores to ensure that the conditioning is not worsening.